Thanks, Jordana. We'll just start at the top. Make our way to call the meeting to order. That was the box wrong. 129. And we need to do a roll call.
Okay, so I'm gonna start with Jordana Carpenter. Here's Josh for Dr. Ziegler.
I'm here, but it's very hard to hear you guys.
You might just have to speak louder. Raymond Proa.
Current here.
Heather Berner. Crystal Fairclough. Ann Stafford. Keep going, Kelly.
There's still an echo. Go ahead and keep going.
Heather Miller. Rachel Muntz. Tony Charizino. Nikki Kovac. Darren Webb.
I'm here.
Thank you. Christopher Gilbert.
I am here.
Now I'll just call the rest of the members as well. Dr. Bradley. Don Bailey. Present. Edward Walensky. Good to see Heather Miller come online. Heather, can you let us know that you're here?
And no one was joining us.
We're good. You now have Julia's laptop audio.
Heather Medler says she's here.
Oh, Adam.
All right, Merlin Curry here.
All right, so do we have quorum?
Yes.
Yes, okay, thank you. So now for the chairman's report. Was it me? Oh, I'm gonna say. Before we begin with the agenda, I would like us all to take a moment to introduce ourselves. Since our committee, we are all present here today. These individuals volunteer their time and expertise to contribute to the work of this committee, and they play a critical role in the decisions and actions we take moving forward. So if you could just give us your name and your role within PACES. I'll start. My name is Jordana Carpenter, and I'm the vice chair as well as the fan representative. So go down the line. So we'll do Joshua Ziegler.
Hi, Josh Seidler. I'm an emergency medicine physician and pediatrician. I work in the East Valley in the Chandler and Gilbert area.
Okay. Raymond Proa.
Yeah, this is Raymond Proa. I am currently a captain, paramedic, and work in the northern and the western region.
Heather Miller.
She might not. Yes.
Oh, okay. We'll go to Rachel Munn.
Rachel, I'm the savings representative. I'm an EMS physician for the University of Arizona.
Thank you. Tony Charizino.
I am the chief flight paramedic for Guardian Air Transport and the EMS Council representative.
Thank you. Nikki Kovac.
I'm Nikki Kovac. I'm the RN representative for AIMS Central Region for the Desert.
Thank you. Darren Webb.
Good afternoon. I'm a paramedic firefighter, shift supervisor for San Carlos Apache Tribe. I'm new on the committee as the tribal representative.
Thank you. Dr. Bradley.
I'm Gail Bradley, I'm the medical director for the Bureau of EMS Trauma System at ADHS, and still also work clinically in the emergency department as medical director for speed.
And Chris Gilbert.
Yeah, my name's Chris Gilbert. I am a flight nurse with PHI Medical and an EMS and outreach pre-hospital coordinator.
Don Bailey.
I'm Dawn Bailey. I'm a family consultant for the Maternal Children's Health Title V program in the Bureau of Women and Children's Health at ADHS.
Okay, Aubriana.
And I'm Aubriana Smith. I am the EMS for Children Program Manager here at the Department of Health Services.
And Mr. Adam Rodriguez.
My name is Adam, and I am the Cardiac Registry Program Manager.
Okay. That's it. So next is a friendly reminder that if you miss 2 consecutive meetings, the Bureau will be contacting you to ask if you are still interested in serving on the committee.
Great. I'll display the schedule.
The 2025 meeting schedule is now available on the ADHS website. Please make sure to review these dates as they have changed a little bit. Oh. Where are they saying that?
We're using Julia's laptop audio at the moment. Do I do a speakerphone?
The folks online, are you able to hear us?
We can hear you.
Yes.
Oh,
Yes.
okay.
I'm guessing if you're
clear.
on that side of the room, just make sure that you talk loudly because it is.
Yeah.
Okay, perfect. Thank you. Sorry, some audio difficulties. Okay, and then so the Bureau report for department updating and staffing announcements. Chief Garcia.
All right. Jordan, I'm going to come behind you so that I'm right next to the microphone just in case. Okay, so apologies as I stand right
No,
here.
that's it.
All right, guys. Well, thank you for letting us give a Bureau report today. I don't know that we get to share this with all of our PACES committee members usually, but the Bureau, thanks to Aubriana's role, sits within, or the PACES, thanks to Aubriana's role, sits within the Bureau of EMS and Trauma System. And so we were going to give a Bureau update today. And we have some slides that we'll distribute as part of your packet for today's meeting. And I will go very quickly, and then I'll turn it over to Vatsal Chakani, who I believe is on the line. Who saw Vatsal, right? All right. So for Crash Responder Safety Week, we just wanted to remind everyone that this week, November 18th through the 22nd, is Crash Responder Safety Week. This year's theme is Responders Ahead, Reduce Your Speed as You Proceed. We've been sharing a big thank you with all of our committees today that we've partnered up with local agencies and many of our sister state agencies to promote some of those resources like traffic incident management training. And we want to continue to give a shout out to all of our responders that help roadside and continue to be safe out there, because we appreciate everything you do. Going on, if we have Vatsal with us today, we wanted to talk a little bit about our annual trauma report and specifically the pediatric trauma data report and some of the work that's been going on the pediatric side. But in the last couple of months, we did celebrate 30 years of the State Trauma Advisory Board. And we wanted to thank everybody that did participate in the development of that annual trauma report that was just approved. It is on our website, and we're hoping that Vatsal can share a little bit more information about that shortly. If we keep going through the slides, Shelley, we'll go to the next one. We do have some EMS portal changes, which I will not belabor during this meeting, but if you do have any agencies that use our Arizona EMS portal or hospital portal hosted by ImageTrend, please take a peek at this information. The most important things to note are that there are some key resources here. If you interact with our portal, you do receive automatic emails from that portal. And the email address we want you guys to flag to make sure it doesn't get stuck in your spam filters is listed here on this slide, azdhs@arizona.imagetrendlicense.com. Please flag that email address so you continue to get emails from us. Finally, the state is rebranding. And I know we have a lot of state officials here in the room with us. You guys know this, but we're getting a new logo. And so as you start to see some of the curriculum and materials that are being branded by this committee and DHS, you will begin to see that new beautiful logo for the state of Arizona. It's in the color scheme of turquoise, purple, and of course, copper. So you'll see that coming soon over the next 6 months. Finally, just some quick staffing updates. We're so lucky we continue to have Aubriana running PACES and working on EMS for children. We also have a couple more staff who aren't here with us today that we wanted to acknowledge with recent promotions. Maureen Adlin, the Bureau's Deputy Bureau Chief. She has officially stepped into that role most recently. We also have Kim Bain, who is our Section Chief of Trauma and Pre-Hospital Coordination. And then I have to share with you guys that I officially transitioning into my Deputy Assistant Director role here at the department, and we will be backfilling the Bureau Chief of EMS and Trauma. So that is a job that will be on our azstatejobs.gov website. It is an ASRS position. And great opportunity, and we hope to be able to find some great candidates that will come and continue to build on that collaborative success from the last couple of years. So please help us to promote and get some of the word out there about the job opportunities, and we look forward to continuing to work with you guys. I think that is all I have. Vatsal, I saw you come on camera, so let me turn it over to you next.
Thank you, Rachel. Good afternoon, everyone. Rachel, I'm going to share my screen. Okay. All right. So let me actually give a little bit of introduction on what do we collect. So we have within the Bureau two registries. One is a trauma registry and one is an EMS registry. And if you see, this is our data visualization page of our website. And we have several dashboards available. Some belongs to, the data comes from the EMS, and some of the dashboards, the data comes from trauma registry. So right now what I'm going to present is the trauma annual report, but I also want you guys to give some introduction to a couple of other dashboards where also we can find pediatric information. Okay. So currently, that's in 2023, we had 33 level 4 and level 3 trauma centers submitting data to ASTR, and 14 level 1 submitted data to trauma registry. Sorry. All right, here we go. All right. In 2023, we had a total of 71,000 trauma cases entered into trauma registry, and of those, 6,568, that is like almost like 9% incidents were among the pediatric patients, that is 0 to 17 years old. So, which is like 6,568 cases. And what we observed in the pediatric patient is the overall mortality is 2.5%, and among the pediatric population, the mortality was 1.5. So 101 pediatric patients died due to severe injury, trauma last year. I'm not going to go into the detail of many of these things because it belongs to the entire population, but I want to show you some of the tabs where you can look into the pediatric population. So each of these page, give us there is a filter available where you can filter it out to look for just the pediatric population. And that is what I'm going to actually do, is filter out for the pediatric population and represent that. So what we have observed is that the pediatric trauma rate for 100,000 is kind of decreasing over the years. It was going it was like very similar from 2017 to 19, a dip in 2020, which overall there was a dip in 2020 due to COVID. And then it again came back to what the level was. And then we saw some decrease in 2022, and it also dipped again in 2023. So it is kind of going down, the pediatric trauma rate. Most of the trauma is unintentional, that is 90% were unintentional, but we still find like 7% assaults among pediatric patients. And if we just want to compare with all the age groups, that's also 7%. So that is kind of surprising, is that if we look at it, all the age group, the assaults are 7%, but among pediatric also it is that high, it's not, it's little higher than the all age population. If we look at the race and ethnicity, it is very high among American Indian population. This is a trauma rate. And if for all age also, we have found the same thing, that American Indian population is at a greater risk of having trauma, followed by Black or African American, then the Hispanic, then white, and then comes the Asian. What we see over here is that the trauma rate is kind of high among 0 to 4-year-olds, and these are mainly comes under these. I think one of the main reason under 0 to 4 is child abuse. Then it is kind of slightly decreased 5 to 9, and then it starts increasing 10 to 14, and then by the time 15 to 17, it really jumps to double the trauma rate, more among male than among females. If we look at the county wise, what we are finding is the darker, the reddish color, the brownish reddish color is that's high, and the dark green color is the lowest. So what we see over here is that our majority of our urban counties, we have a very low trauma rate compared to our rural counties. And this is the same pattern we have observed even for adults also, is the rural trauma rate is higher compared to urban. Talk about some of the trauma mechanisms. And again, you have a filter over here, so you can look at the pediatric population, geriatric population, and all age groups. We will be talking about the pediatric population. What we see is that 29.8, almost 30% of the cases are fall, and the fall is our number one mechanism of injury regardless of the age. But obviously, in the adult population, it is half the cases are fall, whereas in pediatric population, it's 30%. Then followed by the MVT occupant, and that is motor vehicle traffic accidents, which is that makes up 21% of motor vehicle traffic accidents. I think if I look at it, all age group, motor vehicle traffic occupants, that makes up 17% of the total injury, whereas in pediatric population, it is 21.9, so 22%. And talks about like these teenagers driving car. I mean, they have a very high proportion of getting into trauma, motor vehicle traffic accidents. So among the pediatric cases, this was more compared to the other age groups. Followed by then MV non-traffic, and this is again MV non-traffic. These are our mostly recreational related vehicles, ATV, OHV, those kind of injuries we are talking about it. So that compromises, that's a third one, it's 8.8%. Followed by struck by against, and these are mostly unintentional trauma we are talking about it. They are like struck by against, it are, bar fights or against something, banging against the wall or things like that. That comes in the struck by against. Bites and stings and natural environment. This is a very low proportion among adults, or all age when we talk about it. But among the pediatric, it comes up as, the fifth mechanism of injury. And then followed by firearm, which is like there were 238 cases of firearm injuries among pediatric populations. So I can go on like, and then 3%, I was like, that's child and adult abuse cases. And these you will find it more among the 0 to 4-year age. I think we can, So if I click on the fall, and then we can look at, which ethnicity and the age group, how many cases by the age groups, but it also shows you over here some of the outcomes, like how many fatalities among the pediatric populations, what were the total charges, like 57 million total charges because of the fall. Like 2% there was suspected drug and alcohol. almost 46% were admitted to the hospital. So we can look at it we can choose, maybe MVT occupant is what we want to see. It's taking. Okay, here we go. So again, that led to around 16 deaths, around 1% fatality. And I think we will find this goes high. So what we saw in the fall was a 2% some suspected or confirmed drug and alcohol, but you look at over here, it goes to 11% confirmed either drug and or alcohol in MVT occupant. So if I look at it, like, all these injuries like MV non-traffic and everything, we will have a more alcohol. Stuck by against alcohol like 4%, and then the firearms 42%. I mean, that's really high. Like of the 238 cases, 102 cases were either had a suspected or confirmed drug or alcohol in the system. So that is about the trauma mechanisms. I think the next 2 pages, we cannot look at it by the age because of the small numbers. But let me actually just introduce you guys about the EMS incidents. These are another one. Right now, I do not have the filter for the pediatric population, but it gives a lot of information on EMS, total number of incidents, average daily number of incidents, which month and date, and also talks about the demographics, which is like age and county distributions. So what we are planning, I just talked to Abriana last week, and we have decided that we are going to add pediatric population filter over here, so that this entire EMS dashboard is also available to filter it out for the pediatric patients. And when it has it's a good amount of information is available about what are the primary impressions. There are many primary impressions. You can choose the impressions, and it will give you the picture by that particular impressions. Like we just saw the injury, and then we can see over here injury related incident by age and year, and it shows all our pediatric population age and gender distributions over here. So that is about the EMS incidents. We have over here an ATV also, which also has pediatric, I think, population information. Okay, it's loading. Yeah. So over here, we have pediatric population available to select to get the information, and I'm going to select the pediatric population. Okay. Right. Okay. Abriana, do you want to go on? I mean, can I start with the OHV and go into the Quail Kids?
Yes, that's fine.
That's fine. Okay. So what we have over here, these are the off-highway vehicle injury incident dashboard. And what we observed, in our annual report, which I just presented to you guys, is that the ATV injuries, we saw that, were increasing over the years. And especially it started like during the COVID year when people were staying home, and we saw a real increase in, you can see right now over here from 2019 to 2020, there was a jump in OHV injuries. And then it stayed like that, little bit decreased, but it is increasing, especially in the pediatric populations. We saw that. OHV. So then, we decided to, create a dashboard on it and to see, okay, what is going on in it and what is the impact of OHV injuries. So what we see over here is that the injuries are increasing over the years, more among Hispanic population, followed by white. And if you see again, 10 to 14 and 15 to 17 have a higher proportion compared to the 5 to 9 or 0 to 4. If we are looking at the month distributions, it increases like, after January, like it keeps on increasing till May. Then during the summertime, it goes down again, up during the month of September, and like kind of again goes back November. So it's during, except for summertime, it looks like, you know, the AO injuries are very high. It led to 5 fatalities last year among pediatric population, and 21 people, 1.5% were discharged to rehabilitation. The cost for the pediatric OHV injury is $36 million with the median hospital charges of $6,000. Now, this data comes from hospital discharge database, and we also have a severe OHV injuries. When we say severe OHV injuries, that means that is basically coming from the trauma registry. So we are talking about only those cases which were submitted to the trauma center. So why we have these 2 separate database is because, you know, hospital discharge database has information on all the hospitals in the state of Arizona except for the reservation, and trauma registry, we have trauma centers. But then if you see, like, okay, we see the similar pattern, but if you see the number of cases, we are talking about 2,100 in 2023, that is trauma registry, but that does not give you a real picture of OHV, I mean the burden, if I want to see. And that's why, like, sorry, I haven't not selected a pediatric population here. Okay, so it's 600 cases, 647 cases over here in trauma registry, whereas we saw in the hospital discharge database, we had 1,400, so almost, you know, 3 times more than what was seen in the trauma registry. And that is why we actually decided to, you know, have both these databases over here, so we can look at the population wise and then what is happening among the severe trauma cases. So one of the things few things are different from, you know, in the trauma registry, because we capture information on alcohol and drug and what kind of a substance abuse was common. And it also gives you information more specific on the head injury. And we also have a helmet and seatbelt use. So these, so what we saw is that, again, ASTR, we saw the increase. We have total admitted, 34% were admitted of these, and there was a 1 fatality at the trauma center. You can look at it, the 31% developed head injury. And if I do the helmet use, if they were using the helmet, the head injury was 20% in a helmet group, and 39.7% in a no helmet group. Similarly, if I do the seatbelt use, the fatality also, I think it is in that group. The head injury, ICU, in the seatbelt use is not there. You can see the outcomes are, you know, higher. You know, the adverse outcomes are higher in that group compared to the no seatbelt, compared to the seatbelt use group. So after actually doing this analysis, what we decided is, what can we do with the OHV injuries at the statewide? And we presented basically this dashboard and the data to trauma program managers. You know, we have a stakeholders meeting with all the level 4 trauma centers along with the University of Arizona. We meet quarterly in our trauma program manager work group, and we presented this dashboard to them. Now, trauma centers, basically, they also have to do injury prevention program in their community. And so together we came up that, you know, we need to do something about this and have an injury prevention implemented in the community for OHV. And that is where the Quell Kids program came into picture. I'm gonna actually go to some, okay, let me share. So Quell Kids program, we contacted the Department of Game and Fish, and Game and Fish had a Quell Kids curriculum available for preventing OHV injuries. So they partnered with us and did the education to all the trauma program managers. With their partnerships, we started implementing community-based prevention program. The two, I think, are Banner Ironwood Medical Center and Mount Graham Regional Medical Center. Both the hospitals already implemented this education program in the middle school, and I think maybe some high school students. In June of 2024, Banner did it, and in August, Mount Graham did it in school. And Mount Graham had like 272 kids, when they implemented this program. I think Banner did it in one of the classes, had only 16 students, but they also implemented in that classroom. So the Quail Kids program, is basically increases their awareness about, educates them on how the safety related to the ATV vehicles, and what are the safety lines, what are the common cause of mortality while riding this, what to think about it, what in the helmet use, how important is to wear helmet and seat belt, and those kind of things. So it's basically more of an education program around using OHVs. And we did the pre and post test before implementing this program. And so in the pre-test, what you see is that a red color is the pre-test. Some of the questions the kids answered, that is the red color. And then after educating them, we again did the post survey. And what you see in the green is the knowledge on those questions after the implementation of the program. So what you see over here, that we had total 278 kids where the program was implemented. And the questions like, what age may not ride an ATV without a helmet? They didn't know that, if you are a pediatric patient, like less than 18 kids, then you cannot ride ATV without a helmet. Only 24% knew that. And after implementing the program, it went to 58% answered correctly. Some of these questions are based on those safety related, and what we saw is that everywhere the knowledge, that gap, there was huge gap, and then it really like 46% to 87%. Like they didn't know that ATVs, you cannot use it on the road. There, kids say like only 46% say that, yeah, it is only designed for off-road. While after the program implementation, 87% recognize that ATV be used only off-road. So the program, basically what we are right now doing is that we just want to increase we want to educate the kids, increase awareness about the OHV injuries and the harm it is causing and the public health impact it has in the community. We are partnering now with our EMS agencies. We are partnering with more and more hospitals and increasing their awareness so that they can implement this program at the school level. Currently the state is actively involved in doing this. I mean, when I say state, we are partnering with the University of Arizona and all the trauma hospitals. So that is about the Quail Kids. Any question for me?
Okay, seeing none. Thank you, Vatsal. Bear with us. We're going to see if we can go out of order for updates and resources. Dr. Gaither, do you want to go ahead and present?
You're so kind. Thank you. I'm going to walk over to you. I'll apologize to everybody. I have a meeting that starts at 2 o'clock, so thanks for your good time. So let me go early. I'm walking over so you can hear. And again, I'm sorry to talk over your shoulder. For those of you who don't know me, my name is Josh. I'm a physician down in Tucson. For the purposes of this one, I'm the division chief for the Division of EMS at the University of Arizona. The U of A has been working for the past 2 years on a grant to improve quality improvement projects globally for particularly rural EMS agencies. And we developed this tool. So we're going to share this tool with you real briefly, just to really increase awareness that it exists. As you all know, when we talk about quality improvement, we have index case reviews. That's pretty easy. We all do that, chart reviews, that type of stuff. We also do benchmarking, measuring one EMS agency's performance against a goal or national standard. That's what this toolkit is designed to do. It's designed to help EMS agency leaders develop benchmark programs for their agencies. If we go ahead and scroll down to the next page here, up to one more, this really involves 4 processes. First, what you really need to do, of course, is introduce the initiative to your EMS providers. We don't want to sneak up and do something that they don't know is coming. Then the hardest part is step 1, or step 1 is 2 and 3. The arrows are a little confusing. Step 2 is you obviously have to establish data collection and reporting processes, right? That's which fields do we care about and which outcomes are we going to measure. And then the most important part of this process is to establish in your electronic patient care reports what are known as closed call rules. Those EMS providers in the room are very familiar with these. Hospital providers may not be as familiar. These are simply data fields that must be completed in order to close the chart at the end of the encounter. And what we found is this 3rd step is really critical to improving documentation. A lot of our partners really already do outstanding care. We just drop the ball, we all do, when it comes to documenting it. So when you throw those closed call rules in there, we really see improved performance on those national benchmarks. And then, of course, you got to share it back with your providers. If you scroll down to the next page, for the next 2 pages, we kind of outline how you do that, introduce the project, what you do to establish those data collection and reporting processes, and then setting up those closed call rules. The rest of this toolkit goes through really specific examples, right? These are adult-centered examples. We talk about chest pain. We talk about traumatic brain injury. We talk about stroke as keys. I'll offer up for this group a PEDS-centered one that may be of interest to many agencies. That's asthma, right? This would be prime for use in pediatric asthma cases. You could envision the goals of that program being time to albuterol administration, steroid administration for those children with acute asthma, and then, of course, reevaluation and vital signs after that therapy as benchmarks that you could use to measure one EMS agency's performance against the national standard and hopefully see improvement. You're at the perfect stage. If you scroll down just a bit, I'll offer this up as the goal, right? This is too small to see. That's good, right? It doesn't matter what this data set is, but this is the goal of the project, right? Beforehand, on the left side of that graph, you should see that they're documenting the right care about 50% of the time. Afterwards, we really want to see that nice bump up, right? You collect this data, you improve patient care, and you highlight those improvements to our partners, our EMTs and paramedics. Really does help engage those providers. I think the most important component of this project that we've seen over the last 2 years is feedback from our providers who said, wow, we didn't know this was that easy. This really isn't hard, and it makes us feel better about what we're doing. So I'd encourage you to take a peek at this toolkit. Another sneak peek. This is hard. It is not easy to do. It takes a lot of work. So the University of Arizona has developed a 15-hour free online training course that will be coming soon to the DHS website. We just have to get it approved and posted. So hopefully that'll be soon, or it'll be free, available as an online course. It's a 15-hour content developed by Dr. Mary Nuts. That's all I got. I'm happy to do questions. All right, thank you so much. And again, I apologize. I'm going to steal Dr. Rice, and I'll leave you to your meeting.
Thank you, Dr. Cathan. Okay, so then we're going to kind of backtrack just a little bit to updates and resources. So we'll now move on to those. Committee member roundtable updates. Is there anybody that has anything they would like to update us with? No. Okay. Let me go through.
Next.
No. Okay. Arizona Child Fatality Review Team. Morgan.
Hi, thank you. I'll pull up my slides on my end. That's okay. All right, hopefully everyone can see that. Let me make sure Todd's okay. All right, thank you guys for having me today. My name is Morgan Anderson. I'm the program manager for the Child Fatality Review Program in the Bureau of Assessment and Evaluation at ADHS. I'm also joined by Mary Glidden, our office chief for the Office of Fatality Review. And I know many of you may be familiar with the CFR program, so I'll just do a quick little background. But our mission is to reduce preventable child fatalities in Arizona through systematic, multidisciplinary, multi-agency review process. Prevention strategies, interdisciplinary training, community-based education, and data-driven recommendations are derived from this report to aid in legislation and public policy. For today's presentation, I'm not going to go through all of our report findings, just those that may be of interest to this group. However, if there's anything that you'd like more information on or would like me to present at any of your other groups or with partners, please let me know. I'll have my contact information and the link to our full report at the end of this presentation. And then if you have any questions as I'm going through, feel free to come off mute or throw it in the chat and I'll do my best to address those. So just a little bit of background. Our program is comprised of 10 local review teams. They complete fatality reviews at the local level. And the review process is conducted on any death of a child less than 18 years of age in Arizona. Information collected during these reviews is entered into a national database, and that is what is used to produce the data and trends and prevention recommendations that are published in our annual report. And as you can see on the map, those are our 10 local teams. So the same color is a team that is comprised, one local coordinator oversees those counties. And then local team membership includes that list there, plus many more who serve on our local review teams. I think we have some people in the group that serve on their local review teams, but including county health departments, medical examiners, offices, DCS, law enforcement, pediatricians, and family physicians. So just the high level findings from our most recent report. So we reported out 853 total deaths. 32 of those were out of state residents. 415 of those deaths were determined to be preventable. That's 49% of all of the fatalities. 425 fatalities were under 1 year of age. That's about 50% of all deaths. 116 of our fatalities were determined to be from neglect or abuse. Again, 14% of all deaths. Our leading causes of death were prematurity, congenital anomalies, motor vehicle crashes, firearm injuries, and then suffocation. And as you can see on the chart to the right there, that's our mortality rate per 100,000 children. So we did have a decrease from 2022 to 2023 in the mortality rate. And then just at the bottom for our manners of death, looking at the distribution, so natural causes were 58% of child deaths. Accidental injuries were 25%, homicides 7%, suicide 6%, and then undetermined were 3% of child deaths. So now I'll go over just a little bit more information about our child mortality findings before we get more deep into the preventable fatalities. But as you can see, Arizona's child mortality rate has remained relatively stable since 2014. It decreased by 4.1% from 2022 to 2023. The male child mortality rate is consistently higher than female child mortality rate. However, this year, male mortality rate did decrease and the female mortality rate slightly increased. I know this chart is kind of hard on the eyes to see everything that's going on, but this is our top 5 leading causes of death for children by age group. So you can see in that first column there is the age group from birth to 27 days, 28 days to a year, 1 to 4 years, 5 to 9 years, 10 to 14, and then 15 to 17. And then as you move through the columns there, that's the number 1, number 2, number 3, 4, and 5 leading causes of death for each of those age groups. Prematurity was the leading cause of death for infants from birth to 27 days. Suffocation was the leading cause for infants 28 days to less than a year. And then among children 1 to 4 years old, drowning was the leading cause of death. And then looking at our 5 to 9 and 10 to 14-year-olds, motor vehicle crashes were the leading cause of death. And then 15 to 17-year-olds, it was firearm injuries. I did want to note, you'll see in our report as well, for the 5 to 9-year-old age range, we have burn and fire as number 4 for our causes of death. We did want to note that in 2023, we did not see an increase in incidence of home fires or residential fires. However, there was an increase in the number of fatalities associated with those fires. All right, now looking at our preventable fatalities. So in response to the summary data in the report, our state CFR team makes evidence-based recommendations to prevent child fatalities within the state. This process starts at the local level. Our local teams summarize findings and recommendations on each individual case. Those are collected across the state, and we conduct a literature review to support these local team recommendations with evidence-based recommendations. And then our state team reviews these recommendations and subsequent literature to amend, add to, or change any recommendations and approve a final list of recommendations for the annual report. So throughout the report and this presentation, you'll see the term preventable death. Each local team determines if any preventable factors were present before the death. And we label it as 3 possible categories. So yes, probably, no, probably not, or the team could not determine. And really a child's death is considered preventable if the community or an individual could have reasonably done something that would have changed the circumstances that led to the child's death. So looking at our preventable deaths, again, for yes, probably, we had 415. So 49% of our fatalities were determined to be preventable. 47, no, probably not. And then 4% we were unable to determine preventability. Our leading causes of preventable death include motor vehicle crashes, firearm injuries, suffocation, poisoning, and drowning. The manners of death and percent of preventability are undetermined cases. 90% were determined to be preventable, and then 100% of our accidental suicide and homicide cases were determined to be preventable, and then 12% of our natural cases were determined to be preventable. And then looking at our preventable deaths by age group and sex, male children ages 15 to 17 years made up a large proportion of preventable deaths. The most significant percentage of female preventable deaths occurred in female children ages 15 to 17 as well, followed by 28 days to less than a year of age. So then looking at our preventable deaths by race and ethnicity, American Indian and Black children made up 11% and 18% of preventable child deaths, respectively, but only comprised 9% and 13% of the total child death population. So we noted those disparities, and you'll see that noted throughout our annual report and some of our other causes of death. And the majority of preventable deaths were found to be among Hispanic and white children. So again, looking at the leading risk factors for preventable deaths by age group, we can see that for number 1 for our birth to 27-day-olds was poverty, 28 days to a year unsafe sleep environment, 1 to 4 years was lack of supervision, 5 to 9 and 10 to 15 years was a CPS history with the family, and then 15 to 17 years The leading risk factor was substance use. And then among all our total preventable deaths, CPS history with the family was listed as the #1 risk factor. Okay, so like I said, I have some data to some of our specific causes of death. And again, there's more causes of death and more information listed in the annual report, but these are just some that we thought might be of interest to your group. So first, with our drowning fatalities, overall, this rate has fluctuated since 2014. Arizona's drowning rate increased 1.7% in from 2022, or increased 1.7% from 2022 to 2023. Males consistently had higher drowning rate compared to females. The majority of the fatalities occurred among males at 58%. The majority of these deaths occurred among children less than 5 years of age. The disparities that I discussed were noted in drowning deaths, with Black children making up 23% of these deaths, but only comprising 6% of the total child population. And then white children made up 45% of drowning fatalities, but only comprised 40% of the total population. And white children made up the largest percentage of drowning deaths. The majority of our drowning deaths occurred in pools, hot tubs, or spas at 65%. And among the drowning cases where a pool barrier was in place to prevent drowning, the most frequently breached barrier was a door at 48%, or the fence itself at 48%. 47% of door breaches were because the door was left open, and 80% of fence breaches were because there was no fence present. And then while numerous preventable risk factors contribute to drowning, lack of supervision was the most common identified risk factor at 87% of cases, followed by the child's inability to swim at 68% and lack of pool barrier in 58% of cases. So again, in the report, we have a plethora of prevention recommendations that were brought forth by the local teams. We went through a process to identify the 5 most common prevention recommendations that were shared by our local teams and state team. So here you'll find the top 5 prevention recommendations for our drowning cases, which include ensuring availability and accessibility to CPR, increasing drowning education and family outreach to promote water safety, ensuring that public pools and businesses with pools have proper pool enclosures, ensuring accessibility of affordable swim lessons, and creating state fund to help assist families with pool safety devices if they cannot afford them. Next is our firearm injury deaths. So the firearm injury mortality rate in Arizona has increased 171% since 2014. Males consistently have higher firearm injury mortality rates compared to females. Arizona's mortality rate increased by 13.4% between 2022 and 2023. The majority of the deaths were due to homicides, with 59% of the cases being homicides, followed by suicides at 35%, and then 4% were undetermined manner. Again, the majority of these fatalities were among males at 84%, and the majority of them occurred among children ages 15 to 17 years. Again, noting the disparity among American Indian and Black children, making up 12% and 24% of firearm injury deaths, but only 5 and 6% of the total child population. And additionally, Hispanic children made up 47% of the firearm injury deaths, but only 45% of the total child population. And then looking at our preventable risk factors, access to a firearm among users less than 18 years of age was determined to be a risk factor in 60% of our fatalities. And then a CPS history with the family in 59% of the cases and substance use in 56% of the cases. And just to note, when we say substance use, this could be on behalf of the decedent themselves or anyone involved in the incident at the time of the incident. In 31% of our firearm injury deaths, the owner of the firearm was unknown, and the child's parent or caregiver was the owner in 24% of these fatalities. And then in 44% of firearm injury deaths, the firearm user was the child themselves. And most often where the firearm injury occurred, we see it was at the child's home in 35% of cases, followed by a friend or relative's home in 19% of the cases. And then again, for our recommendations for firearm injury death prevention, increasing public awareness that the most effective way to prevent such a fatality is to remove all firearms from households with children, providing parents with education on positive parenting strategies, implementing policies, programs, and initiatives focused on responsible firearm access and ownership, increasing funding and access to affordable community mental health intervention programs, and then having mental health materials present and available in pediatricians' offices and other healthcare facilities, and screening patients for substance abuse and mental health concerns. Okay, moving on to our motor vehicle crash-related fatalities. So this rate has fluctuated since 2014. It's remained relatively consistent since 2022. There was a decrease in male mortality rate, but increase in the female mortality rate between 2022 and 2023. However, males consistently have higher motor vehicle crash mortality rates compared to females since 2014. The highest number of motor vehicle crash deaths occurred among children ages 15 to 17 years old, followed by children 10 to 14 years old. Again, noting a disparity among American Indian and Black children, making up 11% and 15% of motor vehicle crash-related deaths, and 5 and 6% of the total population. And then the largest percentage of motor vehicle crash deaths were among Hispanic children in 37% of these cases. In most of our 46% of our motor vehicle crash related deaths, the child was the passenger. And then most of these motor vehicle crash deaths occurred when the child was in the car, followed by them being a pedestrian in 24% of cases. And then 12% of these deaths occurred on ATVs. Among the drivers in these crashes, 40% were age 19 and above, 27% were 16 to 18, and 12% were ages 13 to 15. Of the 13 to 15-year-olds, 6 were on ATVs. And then while numerous risk factors contribute to these deaths, the most commonly identified risk factors were a lack of restraint use in 49% of cases, reckless driving in 45% of cases, and substance use in 43% of cases. And 17% of children involved in a motor vehicle crash death were not wearing a helmet. And that could be ATV or if they were a pedestrian on a bicycle related. So again, for the sake of time, I won't go through all of our recommendations, but looking at our motor vehicle crash recommendations, we included following evidence-based recommendations provided by the AAP on child restraint systems and passenger safety, continuing to promote the importance of safety seats for children and where they can find locations of certified seat installers, and then some campaigns around safe, sober, distraction-free driving, and then looking at some number 4 and 5 around ATV safety.
you, Morgan.
Just a few more. So for our neglect and abuse related deaths, overall, the mortality rate has increased since 2014 and until 2023. So this year, for our review findings, the mortality rate decreased by 21.8% between 2022 and 2023. Most common manner of death in these classifications was either accidental injuries in 47% and then homicides in 20%. The majority of these deaths also occurred among male children. These neglect and abuse related deaths occurred primarily among infants less than 1 year of age. And again, noting a disparity among American Indian and Black children, making up 12% and 21% of neglect and abuse related deaths and 5 and 6% of the total population. The child's mother was the perpetrator in 69% of these deaths, and the father was the perpetrator in 41% of these fatalities. And then for our risk factors for neglect and abuse fatalities, parent substance use history was noted most often in 71% of cases, and in 63% of prior history with CPS was noted as a risk factor. And again, looking at our recommendations, we just have some recommendations around promoting programs and activities that prevent child abuse and neglect, investing in Arizona families' well-being, financial well-being, including access to supports for food, housing, and childcare, and then looking at increasing awareness on how to report suspected child abuse, and then including increasing access to home visiting and mental health services.
Hey, Morgan. Thank you so much for your presentation. I think in the interest of time, we might have to move on, but could you direct us? I think is the link in the chat for us to review additional information if we'd like to go deeper with the data?
Yes, I think Mary put it in the chat, and then I have a QR code here if people want to scan to get access.
Thank you so much.
Yep, thank you.
Great presentation.
Skip to discussion action items. Okay, so we're gonna skip to discussion and action items. So discuss and amend approved draft PACES minutes from July 18th, 2024 meeting. This is attachment 6A. I'll call for a motion to discuss.
This is Ray. I'll make a motion to discuss.
Thank you.
For me, a second.
I need a second. Thank you. All right, and then any amendments that need to be done? Anything anybody noted? Changed? Okay. Call for a vote. So
All those in favor say
all
aye.
all those in favor say aye.
Aye.
All those,
Aye.
all those opposed? Okay.
Then we
And-
ask for abstentions.
Any abstentions? Okay. It passes.
And then, the result of the vote, so the minutes were approved.
Minutes were-
louder so that everyone online can hear.
Sorry, minutes for approval.
They've been approved.
They've been approved. Okay, as presented, no additions, okay. And then we'll do discuss and amend approve the bylaws to update Article 3, which is attachment 6B. So the bylaw members and terms of membership will be presented by Aubriana to be discussed and voted on by the committee.
Go ahead.
Oh, there's a question, sorry. Go ahead, Josh.
So I hadn't seen these before, so are we going to discuss them now? Because I do have some concerns.
Yes, we're discussing it now. Oh, I'm sorry. I guess I have to ask for a motion to discuss. Sorry.
Okay, I motioned.
Okay, can I get a second?
This is Ann, I second.
Perfect. All right.
So this is just in lieu of, I'm sending over the state partnership renewal. I noticed that there's.
Sorry, I can't hear you guys.
You come over here, yeah.
I'm yelling, I'm using
No.
my outside voice.
Apologies to be standing behind you, Jordana. But this was just in our state partnership EMS for Children program manual. So I figured I would propose this to the group today to extend our membership. I know we've also had additional requests from external people to come on to the PACES committee. So I wanted to be inclusive of some of those roles as well. And then also am proposing today maybe a term limitation with the opportunity to renew every 3 years. So I would love to hear the feedback from the group today on the members and that term limits. Yes. Awesome. Dr. Zeidler, you expressed interest in
Sure,
that?
I'll be happy to start. So term limits, I thought we expire at the end of 3 years anyhow. So are you guys saying we should be ineligible to run again? We'll start with that. That's easier.
So my apologies, Dr. Zeidler, as I'm going to use the new card. I'm still relatively new to the Bureau. I was not aware that we already had term limits, as our bylaws state that there is no term limit. With this in place, you would be eligible for renewal every 3 years. So if you want to still continue serving in your role, then you're more than welcome to, as long as you're in good standing with the Bureau.
Okay, I mean, I don't have much concern about that. I would like to address this huge list of additional members.
Yes.
And I don't doubt that each one of these categories has something to add. But I find that if you add this many people to a committee, you will accomplish nothing and spend all day just listening to other people. So, my suggestion would be we keep the committee small, maybe add a couple, and then all these people are invited to come and discuss any of their needs or wishes to the committee. But I'm not sure they all need to be included as voting members.
Thank you, Dr. Zeidler. I want to open it up for anyone else. Tony?
Concern I have is quorum. If we increase to a size of 38, we struggle to have quorum and we need 7.
Yes.
So for us to be able to move things through the committee or through the council, that would become a challenge.
It's very valid. Yes, Dr. Munn?
Is there relevant backstory that we should know and consider with this list of members and why it has gotten so large and why certain of this larger list, are there a handful of people that as a group we have felt very strongly about being voting members, or is there backstory that I just don't know?
Yeah, I would be happy to provide that. So the EMS for Children program in its entirety at the nationwide stance typically has these members for their larger states. So I've been attending those meetings, seeing a lot of people contribute to those. Specifically for our program within Arizona, I think we're working on some disaster preparedness initiatives that we would like to have some more member feedback and input on and bring those experts to the table, as well as our pediatric emergency care coordinators. That's going to be something big that's going on in the state in the next couple of years. And then I know that we had a tribal emergency department physician interested in coming on as well that I think would be great representation to have. Does that help to answer some of your questions, Dr. Munn?
Sure. If the rest of the voting members are interested in maybe shortening this list, are there a few of these proposed voting members that we feel very strongly about? Is it kind of a middle ground in terms of expansion that people are interested in, or is it an all or nothing?
No, it's up to the group, however many we would like to include. I want to make sure that everyone has a voice here, and we're adding the people that we think would be best to the group. So I can share who I would like, but
A larger committee to form is a big issue, so we do see that in our other meetings because this falls under our public meeting laws and rules. We are very saying that we can't actually continue the meeting or vote on anything. We don't need quorum, so that is something to work out with the meeting. So how many people, as mentioned, 7 doesn't sound like a lot, but we have not made quorum in this meeting. So we have had issues with meeting quorum in this group.
Can I ask a clarifying question? Is it the intent to add all of these to the PACES, or is this just a reflection of all of the seats that are represented in other states for us to kind of have a look at?
Yes.
From those agencies.
Yeah, so it's the latter of the two, and this is in our state partner EMS for Children program manual of recommended officials to have on the committees. So I'm not saying that we include everyone, because I agree quorum would be quite a challenge, but I think we should add a few more to the group.
Got any specific interest from any of these seats of people in Arizona?
Yes. Would we like me to highlight the ones that I've gotten interest for? Okay.
Please.
I cannot see the screen. Can I move this over to my laptop? No, it's okay. Oh, thank you, Shelley. Okay. So the tribal emergency department position is one. You still can't hear me?
I'm sorry.
Okay. And then I believe the pediatric emergency preparedness representative would be something of value to this group, as well as an injury prevention representative. As we saw today, there's a lot of areas that we should be preventing on, but we also need to be prepared on in the future. EMS for Children program has been doing a lot of work with the highway traffic safety group. So it could be beneficial to have, but I understand if the group does not want to expand it to that member at this time. But I do believe the pediatric emergency care coordinators do need to be a voice within this group, as well as some of our pediatric trauma program managers or emergency physicians, and then the child fatality review representative as well. So that is what I have highlighted. Anne, I see your hand.
Yeah, can you clarify for me? So number 16 on the list is pediatric emergency preparedness representative. Can you kind of clarify for me, like who that might include? Who would qualify for that?
Yeah, so we have several organizations that we work with throughout the state with EMS for Children. So they coordinate disaster preparedness initiatives. They do disaster preparedness training. And so that it would be that open to that individual.
Great. I would recommend we consider that as one of the additions.
Thank you, Anne. I do also want to highlight that we have had requests from school nurses to be a part of this. We can maybe have them come and attend the meeting. And then if we see that their voice could be needed, maybe add them in the future as well. But I have had some requests for that.
So maybe I think one thing that could be beneficial is, you know, these are open meetings. So I think that is one of the things to keep in mind with this committee is that maybe what we need to do is a little bit more work on kind of communicating these are open meetings. They're open to anyone to be in person. You can join virtually and have a say and speak up and participate in the meetings. And so that might be a bridge to get a little bit more participation with people who are interested, just because this is really specific for advisory council for emergency services. And so we want to make sure that the focus is still very much kind of emergency services related. And so sometimes when you get other groups in here, they bring very valuable pediatric things to the table, but they might not be kind of specific or relevant for the EMS community. And so maybe that's an opportunity to get more involvement and participation, is to have them come and be at the meeting, participate, and provide feedback and insight.
Okay. Thank you, Dr. Bradley.
Is there an opportunity for these maybe more work groups instead of voting members on the entire committee as well?
Yeah, that's an opportunity, yes.
If there's specific initiatives we want to try to accomplish, I don't know. I'm struggling to see like long-term how there'll be continued things for us to do for the EMS side of that. But I think that there might be a likelihood with between the open rules and other initiatives that may come to the table for us to actually resolve.
Okay.
But for years and years going forward, I'm struggling to see how we would still see that or find something to pinpoint to actually work on to get through to completion.
Very valid. Thank you, Tony. Awesome. Is there any additional comments?
What are we trying to accomplish today? Are we trying to finalize this list or just table it and come up with specific names for next time? help me figure out what our goal is.
I would say our goal today would be to delineate this list down to who we think would be beneficial to be on the committee. If we don't think anyone, then we close it and just potentially have work groups in the future.
Thank you.
But I do also want to highlight that I am recommending changes to voting member status as well. You can see on number 34 and then number 35, I'm recommending that those become voting members.
And was added to the chat, like proxy voting.
Do we have other ADHS members that are voting members on any other type of committee?
Dr. Bradley or Shelley? Do we have any other ADHS voting members on any other committees?
No, but this one's different. It's grant funding.
What would Kelly's answer?
Oh, this PACES committee is different as it's a grant funded committee.
But in terms of voting members,
The other committees, I think IPAC is a
but like
representative.
MDC, those ones,
Oh, no.
yeah,
not this
ADHS personnel are not voting members of that.
I mean, Gail is chair.
But I don't,
No.
All right, Dr. Zeidler, did you hear that feedback?
Yes, I did. Thank you. Yeah, I just thought it a little weird because most of the DHS, employees and staff are not voting members on any other committee. I appreciate all of their input, but I didn't know if there was a history as to why they were more advisory as opposed to voting members.
Thank you, Dr. Zeidler. Like I said, I just wanted to present this to this group, maybe just have the feedback. I've been appreciating this discussion. How would we like to move forward? Would we like to cut down this list and maybe have a couple more members come on so it's not a major issue or concern with quorum, or do we want to table this?
I think this tabling, I'm not sure will be.
Okay, so we'll table this, have the committee members look over it, and then readdress this at the upcoming next meeting in March.
How about a work group or some other email groups to try and trim the list down between now and the next meeting?
I like that idea, but I don't know.
Well, the last item G is a standing item to discuss and approve work groups. We could at that point form a work group to do the bylaws.
and we have with the other committees, we have had a bylaws work group. So for our other bureau committees, we do typically have a bylaws work group that's a smaller number of individuals that review them and provide recommendation for the entire committee to vote on. So if we have that as a standing item, that would give us that flexibility.
Okay, so would that work group be just for committee members? Because I do see Anne's chat in here about proposing a potential additional bylaw change to allow for voting.
We generally allow anyone to participate in our work groups. So it would have to be the only one, because it should only be the person who's voted. Is that what she's asking?
She's asking if we want to expand the bylaws to have proxy voting in place of just members. Is that?
For the whole PACES council, not the work groups.
Yes.
You'll put that on for the work group to discuss.
Yeah, we have tried to keep the bylaws consistent amongst all of our bureau committees, just for consistency in managing, and we do not use proxies for any of our other committees.
Okay.
Just because of challenges of making sure that it's truly the proxy of that individual's voice that's on the committee. So that is not something historical. It's certainly something that subcommittee can discuss and come back with, but none of our other committees allow for proxies.
Okay, thank you for that background.
Okay, so I'm gonna.
Ariana, I'd make a motion that we table this. We can discuss that when we get to the bylaws and the work groups. Continue that discussion further.
Yeah, okay. So we have a motion. Anybody want to second that motion to table this discussion?
This is Ann, I second.
Perfect. So we will table this for our next meeting.
Yeah, I'm sorry. So were we going to do a work group? Because otherwise we're just going to come back to this in 3 months and look at a list of 35 people and not get anywhere again.
Yes, we're going to get a work group put together.
Okay. Awesome. Thank you.
It's further in this meeting. It'll be item G.
Sorry for being a pest.
That's okay. So
Next on the agenda.
next is discuss and amend, approve the EMS Pediatric Emergency Care Coordinator Role Description Guide. So this is attachment 6C. The EMS PEC role description guide will be presented and discussed and voted on.
You want to talk? Come back.
Sorry.
Here and talk to you.
Sorry, Brianna's going to come and discuss this part as well. So give us just one moment.
Getting my steps in today, guys. Okay, so this is a draft item that EMS for Children is proposing to the council today. This is our EMS Pediatric Emergency Care Coordinator role guide that we developed in conjunction with our federal recommendation. So this is currently what is on the National EMS for Children webpage. We've just tailored it to be Arizona specific at this time and taken some things out, specifically with the medical director clause. We're having that be the same as the operations leader. So this is just the role guide. Just tells EMS agencies how they can function with a pediatric emergency care coordinator within their agency. I'd love to hear any feedback that you all may have.
This is Anne. I had a chance to look it over and I think it's fantastic. I feel like it's the first real coordinated effort that we have to define that role. And we will be taking this to our PPEC steering committee to talk about incorporating that into the program and making it a potential criteria that they have a designated PEC to be a PPEC certified hospital.
That is excellent. Thank you very much, Anne.
You did a great job. Thank you.
It's Seidler. I went through these as well. I thought they looked great and hopefully could give guidance to people who are trying to develop this role.
Thank you.
Or is this something to vote on, or what are we doing with these as well?
It's a voting item.
We'll take a motion.
I'm going to ask for a motion to approve.
This is Anne. I motion to approve.
And Seidler, I'll second.
Thank you. And so it is approved.
Well, no.
No? Oh, vote. Sorry. I'm sorry. Get used to this. All in favor, say aye.
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 All in against it, say nay. Perfect. Any abstentions? Okay, now it passes. Okay. And then hospital one. So next is our emergency care, the same thing, but for the hospital side. So this is attachment 6D. So we'll go ahead and motion to discuss this.
Motion.
Thank you.
Second.
Thank you. Any comments or questions on this? No? Okay.
I'll motion to approve.
Okay. Thank you. And do I get a second?
I'll second.
Who was that?
Christopher Gilbert.
Thank you, Chris.
Okay. And then all of those in favor say aye.
Aye.
All those opposed say nay. Any abstentions? Okay. And it passes. What's next? That's correct. So, so discuss and amend, approve joint PACES and EDU work group to discuss training with SHIN. So Abriana will be presenting this EMS guidelines for SHIN, seeking discussion and approval on forming work groups to review this document in greater detail and derive training materials from it.
Yes, so I don't know if I'm assuming the group had a chance to look over this, but we presented this document to the Education Committee this morning for a proposal to have a joint work group. The Education Committee has agreed to participate in this. The goal of this is to have an established guideline for EMS to look over children and youth with special health care needs. And hopefully in the future, we can also provide additional training from this guideline. So I'm just seeking your feedback on that if anyone would be interested. And then I will kick it over to Jordana for any motions.
So call for motion to discuss.
Okay.
So a motion for discussion.
We're just approving the.
We're just in print. Oh, sorry.
Approve the work group.
Oh, okay. So we're just going to approve of. So motion for a work group.
Rachel.
Thank you. Do I get a second for our work group?
Zeidler, second.
Thank you. All those in favor say aye.
Aye.
All those opposed say nay. Any exception? Okay.
And then can we get, does anyone want to volunteer at this time to volunteer, to be on this work group? Rachel, none? Okay.
It's Zeidler, I'll volunteer.
Yes, you can. Dr. Zeidler, Don Bailey,
Allison.
Chris Gilbert.
Okay. Thank you.
I would like to be on that as well.
Deb Repke.
And if you have any other, later on you decide you want to, please just shoot us an email either to Aubriana or Shelly, who's on the agendas.
I wrote down Rachel Munn, Josh Seidler, Don Bailey, Chris Gilbert.
Deb Repke.
And Allison.
Okay, excellent. Perfect. And Allison.
Mhm.
Awesome. Thank you, guys.
All right. So moving on to letter F. So this is our safe sleep training and toolkit. So this is attachment 6F. Aubriana or Gilbert will be discussing this. Which one of you want to?
Chris, do you want to do it? Chris Gilbert?
We can get this step away during education committee.
Oh,
Just
Okay. So I'll just provide a quick update. So we drafted some, or excuse me, we had revised some safe sleep training that was previously grant funded through ADHS, and now it is not grant funded, but we still believe that this training is valuable for EMS providers. So PACES and the Education Committee formed work groups on 2 separate meeting occasions where we did the training on the first one. You can see in attachment 6F, and then we did the toolkit as well. The training just demonstrates updated data from the child fatality report, as well as updated bed measures that may be at risk for the pediatric patients, such as cords. We also put children and youth with special health care needs considerations in there, and updated some resources for families to access. In the toolkit, it was more scenarios based. The majority of information remained the same. We did just update to add cords as a potential risk factor for cribs. And then we added some additional training opportunities or resources for EMS providers to access, as well as the post-test. Do we have any questions about that attachment? Allison? Lucas?
was this built off of that one that Yomi's like the injury prevention, ADHS prevention used to do in someone? We worked with them a little bit on this, along with the
So the question that was asked was if this was through Yomira Castillo's program within the Injury Prevention Bureau, to which Julia confirmed that that was yes, along with AZAAP and additional members.
I said it was based out of PACES, but we collaborated with Injury.
Thank you.
AAP.
Excellent. Thank you. Okay, is there any feedback or additional questions pertaining to this?
We'll get it cleaned up and posted shortly.
Okay. So what do I need to do anything with that one?
Nope, that was just
good. Okay, so then moving on to our standing items, which is our discussion and then improve work groups. So I would like to have a motion to approve a work group for the bylaws discussion. Perfect, thank you. All right, all in favor say aye.
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 Thank you. Any opposed say nay. Perfect. Okay. So then we have a motion to move for a bylaws work group.
All right, let's collect some names for volunteers.
Anybody want to volunteer to be on that group?
Ed Seidler, I will.
This is Anne. I can do that also.
Thank you.
This is Ray. I'll be on it.
Thank you.
Chris Gilbert.
Thank you.
Right, I wrote down Tony, Josh Seidler, and Ray Pereira, and Chris Gilbert. Did I miss anybody?
Anybody else? If you think about you want to join later, just let us know. Either email Shelly or Aubriana. Both their emails are on the agenda.
Did we want to revisit Jesse for?
Oh,
we're not on that.
no, yeah. I was going to do the call to public.
Yeah.
Okay, so call to the public. So we're at the point in the meeting where we open the floor for public for any comments or questions.
We have
Chris-
one over here.
Chris-
McCarthy.
Yep, go
I'll
ahead.
come over there real quick.
Thank you.
Hi, Chris McCarthy, representing Western Region Alliance for Pediatric Emergency Management and the Pediatric Pandemic Network. And there is a quality initiative collaborative that Pediatric Pandemic Network has initiated. We're in the third month of 2 years, and it is still open to any interested hospital. It is based on the EMSC's checklist for essential pediatric considerations for disaster planning and policies. So again, heavily focused on children's hospitals, but it is open to any hospital that's interested. And we currently do not have any hospitals from Arizona. So no guilt trips, but if there's any interested parties, there's a lot of information. I know Aubriana is sharing the link, and Aubriana, if you can pop my email in there as well. I'm a local contact. Thank you.
All right. Anybody else have anything to say? Nope. Okay. So upcoming events, we have some conferences in January, February, and March, if you want to take a look at those. And then next meeting is in March 20th, 2025 at 1:30. Okay.
Go ahead and adjourn.
So I'd like to adjourn the meeting at 3:01.
Great. Thank you, everybody.
Thank you, everyone.
Sorry, first time.